This lecture will be on mammography. So when we bring a patient in for a mammogram, it's not actually real easy work. It's repetitive work, and the breast size is very different between every patient. So the density of the breast, the shape of the breast, and getting a good mammogram is not as easy as it looks. It never fails when you work in mammography that the women are like, if only a man had it done of his unit. So this is what I put in here for you. So the Manogram, I think it would be fair. All right. So the introduction and history. Breast cancer is second only to lung cancer for causes of death in women. Death rates have decreased. It doesn't mean that the actual diagnosis of breast cancer has decreased. If anything, I think it's increased with the population, but we are treating the patient, so the death rates have decreased, which is really, really cool. So it became a reliable tool in the 50s, and I'll show you some of the equipment and how we did it, which is really crazy. So 200,000 women will be diagnosed with breast cancer each year, and that number is climbing. A woman's lifetime, the risk of breast cancer is 1 in 8. So the greatest risk is age and being female. So really, really tough. If you just look at the people in your class, 1 out of every 8 of you probably will be diagnosed with breast cancer. So it's a little crazy. We recommend annual screening for mammo for women over the age of 40. So we try to do early detection. We can't prevent breast cancer, but if we detect it early, there's a huge benefit for women with higher survival rates and less treatment. So therefore, less long-term side effects and healthcare costs, which is great. So that was a duplicate slide. Sorry about that. Research conducted in 1970 clearly showed that mammo can be an essential part of the diagnostic program. So mammography was first and only federally regulated imaging examination with MQSA, and we follow MQSA standards still. So Mammography Quality Standards Act is what MQSA stands for. It's FDA oversight, a standardization of imaging quality, radiation safety, and positioning, and the techs must be certified in order to do mammography and uphold the MQSA standards. And there's a lot of them. Very, very regulated. So breast cancer screening is defined as a procedure performed on an asymptomatic patient, or a patient who presents without any known breast disease or issues. So the American Cancer Society and American College of Radiology recommends annual screening for women older than 40. Diagnostic mammogram. So you'll hear us say, is it screening or a diagnostic? So screening is no evidence of breast disease to the patient, and diagnostic is when there's clinical evidence of breast disease. So they feel a lump, there's reddening of the skin, there's a million different things. It's painful breasts. So problem-solving examination that uses specific projections to rule out cancer and demonstrate suspicious areas. And it could be after a screening mammogram is done, they come back for a diagnostic. So risk factors are increasing age. The older we get, the higher the risk factor is. And we have obesity, postmenopausal hormone therapy, physical inactivity, and alcohol consumption are also risk factors. Having dense breasts are risk factors also. So they say dense bones and a family history of breast cancer is also a risk factor. And they want to know if it's on your mom's side or your dad's side as far as the track of breast cancers. And you can also get DNA checking to see if you carry the breast cancer gene. So the anatomy, the terms breast and mammary glands are the same. So there's lobulated glandular structures located in the superficial fascia of the anterior wall of the thorax. So female breasts are a secondary sex characteristic. And female breasts are considerable in size and shape. So it all depends on the amount of fat and glandular tissue presented and conditions of the suspensory ligaments. So age has a lot to do with glandular tissue. The younger you are, the more glandular tissue you have. As you get older, it becomes what we call fatty replaced. And those ligaments just don't hold up over time. So that's where you see the women with the breasts pointing straight to their feet. Those ligaments are not keeping the breast perky as we would love. So breasts are usually cone-shaped with the base overlying the pectoralis major and serratus anterior muscles. And as you can see, there's a lot of different sizes and shapes. And the axillary tail of the breast extends from the upper lateral base to the axillary fossa. So it goes from all the way up into like the armpit area. So you can reach up and grab the tissue that's along your chest wall right in front of your armpit, and that is your axillary tail. So the anterior end tapers, ending in the nipple. The areola surrounds the nipple. It's a circular area of pigmented tissue or skin. The Cooper's ligaments support the breast, and like I said, when those ligaments go bad, we start to get the saggy breasts, and it just happens with age. It's called gravity. So 15 to 20 lobes in the adult female breast. So each lobe is divided into lobules. Lobules are a basic structural unit of the breast. It contains acini, draining ducts, and interlobular stroma or connective tissue. So lobe size affects by age and hormones. Involution is the normal process of decreasing lobe size with age and after pregnancy. So acinis are glandular elements of each lobe. Lentiferous ducts form by openings of each acinus. So lentiferous ducts form by joining ductules. So one duct for each lobe. Ducts join before opening into the nipple. So I'll show you a diagram so it makes a little bit more sense. And those of you that are taking the breast course, this is just seriously skimming over the breast. So this lecture is mainly for the men. This will be very elementary for you women in mammography, but for the men, they have to know the basics, so pay attention. Lymphatic vessels of the breast drain into two sets of nodes. So there's the axillary lymph nodes, which are laterally, and internal mammary lymph nodes, which are medially. So usually if there's a breast cancer, we'll check the lymph nodes to see if it's hit the lymph nodes. And you'll hear about an axillary lymph node dissection on women with breast cancer. You'll hear it all the time. Axillary nodes are often evaluated on mammograms. So we want to see and make sure those nodes are of normal size. So here is your diagram. So you have your alveoli, you have your lobes, and you have your Cooper's ligaments. So these little guys keep the breast perky. You have fat, which is normal, and you can see this is a lobe. And you have your connective tissue within it, subcutaneous fat just under the skin. And you have your ampullas here and your areola with your nipple, and you have the duct draining out. So glandular tissue increases during pregnancy and lactation, decreases in postpartum and with age. Connective tissue, dense and cast homogeneous shadows, primary component of post-pubertal adolescent breasts. Fatty tissues replaced glandular tissue after lactation and advancing age. So yes, our breasts just become fat instead of glands. And it increases the contrast. So here we're going to talk about the history, and we're going to show you full film digital along with CAD. So the mammo equipment, so we have dedicated units. They have high frequency generators. It gives us more precise control of our KVP and our MA and time, and specially designed to produce high contrast, high resolution images. So it's a different equipment than what we use in diagnostic. So early imaging, we imaged mastectomy specimens, and we did chest x-rays. And you can see here in the 30s, look at that cone, big old cone on there. Pretty smart using a cone, actually, back in the 1930s. Should have cleaned up a lot of the scatter that degraded the image, but I can't imagine that they had really good film back then to where we could see the detail that we really needed. So here in 1966, you can see pretty much the same, not much has changed. In 1975, we came up with a dedicated unit. And MD Anderson in 1965. And these were the normal views, the craniocaudal, mediolateral, and axillary, and we still do these views. So we started using compression, and they used a balloon to compress the breast, and we just used the normal X-ray machine with a cone on it and a IR, so a film. Then there was zero mammography. They just call it zero, and you can see here the breast, which actually is pretty good, and it has like this powdery stuff, and we get it all over our hands. Patients would bring them in, and that was just back in 1987. It wasn't that long ago. And they come in with these cardboard box, like cardboard envelopes, and it had the powdery material image inside, which always got everywhere. Then we went to film screen in the 80s, where we had compression. So we applied compression to the breast, and this is a dedicated mammo unit. And they came out in 2013 with the dedicated tomosynthesis. It's been FDA approved. It's awesome. And we had the Selenia digital in 2002. That made a huge difference in the world of mammograms. The tomosynthesis, which is the 3D, it does post-processing so that we can get breasts, we can see all the way through the breast just like a normal tomogram, and we can do it with different thicknesses, and we can have it look like a normal mammo in addition. So the patient is exposed to additional radiation, but yet we see so much more than what we would just on a basic mammogram. Okay, so mammo is the highest quality x-rays, and we use really low kVp, so 24 to like 32, and really high mass. The mass can go up to like 250. It's crazy. So regular x-ray, the anode is tungsten with aluminum filter to reduce unnecessary exposure to the patient, whereas in mammo we use molybdenum target with molybdenum or rhodium filters to enhance contrast sensitivity. Also, there's a lot of heat. We're using really high mass, so we use a molybdenum target with rhodium filters. And then the 2D, 3D tomosynthesis units uses tungsten with rhodium or silver filters to reduce dose and give us the best possible contrast. So patient care, we're going to talk about importance of history taking, education and informing the patient, and awareness of patient's state of mind and comfort and patient's anxiety. A lot of mammo is calming the patient. So for the procedure, they dress so that the gown is open in the front. You guys are used to having it open in the back. It's opening in the front. The breast must be barred from imaging, so you need to remove all clothing, all image artifacts, anything that they can. If they put powder on, they've got to take the powder off because it looks just like calcifications. Deodorant also has little specks of metal within it, so they have to remove their deodorant. All of that can look like breast cancers, and they'd be called back for unnecessary workups. So when we take a history, you have to be careful that you include everything. So we talk about family history of breast cancer on mom and dad's side, any history within themselves, any biopsies that they've had, any issues that they've had with their breasts in the past. We make notes of all their scars, masses, skin abnormalities, nipple alterations. Patients will get an inverted nipple. We need to document that so the radiologist knows that that's been a change. Examine previous mammograms for positioning, compression, and exposure factors, and we need to see what we can do differently to improve upon the prior. We have to explain the procedure to the patient, including possibility of additional projections. I always tell my patients, don't panic. We call back like 20% of our patients across the board. Breasts change throughout time. If you're not coming in yearly, your breast can change a lot within a year to 2 years. So you can be called back for changes in size, shape. So don't be surprised. It doesn't mean you have breast cancer. It just means that we want to document the changes. And we support the breasts. We look at the mobility of the breast before positioning and decide how we're going to do it. We support the breast firmly so the nipple is directed forward, and we want it in profile. We apply proper compression to produce uniform breast thickness. That's the reason why we do the compression, is so that the breast is uniform in density when we make the exposure. It gives us better quality. And you also want to make sure that you get all the markers on the correct side. I'm really funny about my markers, you guys know that. So you have to have on your markers somewhere on the actual film or image, there's got to be the facility name and address, examination date, patient name, age, date of birth, and medical record number. Now that you guys are all digital, this comes up automatically, which is so nice. You have to, so we go A through G, so A, B, C, D, E, F, G. All of this has to be on your film. So A, you've got, we just talked about. B, you have to put the side in the projection. C is the technologist's initials. We have to know who did it. It's not an option that it's not on there. It has to be on there. You need to know the image receptor number. So if it's not a digital unit, it's a CR unit, it's got to have the IR number on there. The date has to be on there. Your exposure factors have to be on there, and the unit number. So sometimes the X-ray unit itself will have an issue, not the IR. So now with the full field digital, it's all encompassed, so it's one unit, which is nice. So A through D is required, E through G, so the date, the exposure factors, and the unit number don't have to be on there. Typically we'll write it on there so that we can see it. It says optional. We usually do it, and the digital units do it for us, which is really nice. So when we're doing a screening mammogram, we do a CC and MLO, craniocaudal, and a mediolateral oblique. When we're doing a diagnostic, we do the craniocaudal, the MLO, so the mediolateral oblique, and a lateral medial also. So when we're doing the craniocaudal, you have the patient standing. Typically, we don't have them sit, they stand. You elevate the breast, so it's within normal height, coming straight out from the patient. You adjust the IR so that the inferior surface of the breast is lined up with the bottom of the image receptor. You gently pull the breast into the IR with both hands, holding and instructing the patient to press their chest up against the IR. So you want their ribs right up against the IR and kind of digging into them. Let's see, so the breast is perpendicular to the chest wall. You center the breast over the AC. You place the nipple in profile. You don't want it tucked under the breast or pointing straight up. You want it straight into the machine. You immobilize the breast with one hand. You use the other hand to move the breast out of the image, and I usually put it on their shoulder and tell them to relax and externally rotate their shoulder. And you have them turn their head away from the breast being examined, lean toward the machine, place the hand on the shoulder and on the side over the clavicle. You compress the breast slowly until the skin is taut. You don't want it super tight, but you don't want it loose either. You want it nice and snug, as I say. Exposure is made on just holding your breath. So after the exposure is done, it automatically releases the compression for the patient. So the CR is perpendicular to the breast. So the medial, so that's the CC. So you're just going to bring the patient straight into the machine, nipple heading straight in, and you're going to compress it till it's taut. So when you're doing the MLO, you're going to have the patient stand. You're going to rotate the unit so the long edge of the IR is perpendicular to the upper 1/3 of the pectoralis muscle, so the upper muscle that I had you grab earlier. So you're going to angle it to that. So the degree of obliquity is 30 to 60 degrees depending on the body type. So what you're going to do is you're going to place the top border of the IR level with the axilla. You're going to elevate the arm of the affected side over the corner of the IR. You're going to rest the hand on a grip adjacent to the IR, and the elbow should be flexed. So you're going to lay them across the top of the machine. have them relax their shoulder and have the patient lean slightly anterior. So I turn them so that their feet are straight into the machine. So, and then you just bring the arm straight across up over the top. You're going to place a hand along the lateral aspect of the breast and gently pull the breast and the pectoralis muscle anterior and medially. So you're going to pull the breast up onto the IR. Holding the breast with the thumb and the finger, lift up and out. So you're going to pull the breast up and into the machine and away from the chest wall. You're going to make sure the body is facing straight into the machine. Ask the patient to slightly bend at the waist, and that'll pop them right into the IR perfectly. Center the breast with the nipple in profile. Hold the breast up and out. Compress the breast slowly until taut. Pull down on the abdomen tissue. So a lot of times the belly fat gets up into the fold, infomammary fold. So you just take them and kind of push their hips back and to pull the fat away from the breast. Instruct the patient to hold the opposite breast out of the anatomy. So a lot of times once you get them in compression, the other breast will be shadowing onto your breast. So you have them pull it back. Sometimes you have to pull their shoulder back a little bit too to get that shadow out of there. So you make your exposure just on suspend respiration. Just hold your breath. Don't move. Hold very still. And it automatically releases. So the CR is perpendicular to the base of the breast. CR angle depends on body habitus. So if they're real tall and thin, I usually go to the 60 degree. Where if they're kind of short and stocky, I'll usually use a lower, lesser of an angle, more towards 30. All right, so imaging criteria. So for your CC, your craniocaudal, you want your posterior nipple line extending posterior to the edge of the image, so measuring a third inch. So on MLO, so basically what you want to do is just make sure your nipple is centered on your IR and in profile on both. Tricky. So all medial tissue is included. You want your nipple in profile, and we are looking at the medial tissue. So you will miss some of the lateral tissue. It's not possible to get it all on a craniocaudal, but the medial tissue is your concern. So you want to make sure you get all the medial tissue. On your MLO, we get the lateral. So your pectoralis muscle is seen posterior to medial, and we can see it on about 30% of the cases, so we don't get it all the time. You want to see some cleavage of the other breast, so you'll see it hanging off the edge of the cassette, and you want uniform exposure. So here you've got your muscle pectoralis right there. We can see the cleavage right here of the left breast is right here. So great cleavage shot. We know we've got all the medial tissue, and you can see it starting here, so we know we've gotten all the medial tissue. We have a little skin fold right there. That's pretty hard to get out. So your medial lateral oblique, your MLO, your nipple PNL measuring within 1/3 of your CC, and your inferior aspect of pectoralis muscle extending to the nipple line. So you'll go straight back from, so here you have your nipple here. This is your nipple line right here. So you go to the middle of the breast, out to the nipple. You want it to be as straight as possible. So for your MLOs, I'm going to show you the nipple line. So you want it within 1/3 of the PNL on CC, inferior aspect of the pectoralis muscle extending to the PNL or below, your pectoral muscle showing anterior convexity to ensure the relaxed shoulder. And you want the nipple in profile. You want to open infomammary fold, and I'll show you what that is. Deep and superficial breast tissue well separated. Retrogranular fat is well seen, and uniform tissue exposure. So here, nipple line right here coming back, and nipple line right here coming back. Here's your muscle, and you want it at least to the nipple line. So they did a phenomenal job on this mammogram. You almost have it all the way down. Now the infomammary fold is right here on both sides, and a lot of times the belly will come in and overshadow. So they did a good job pulling the belly out and down so that's not part of the image. So the idea is to take this breast and pull it up and out. And so if it's going straight down here, you want to take it and pull it up and out as much as possible so that you can see all the ligaments being pulled straight out. Okay, other modalities that we can do. We can do stereotactic biopsy, there's ultrasound, there's MRI, there's nuclear medicine, and there's PMEs, which is positron emission mammography. So a lot of different things to learn about the breast. We have a whole course on it for whoever would like to take it. We will get you rotating out in clinic also so that you can sit for your national exam. So there it is in a nutshell. Very, very basic, a lot to it. So this is just what you need to know for your national exam, because there will be questions on your national exam for you to answer. So be sure you understand it. Thanks.